Aloha, welcome back to General Pharmacology. Let's move the PowerPoint slides and get started. We have plenty to cover. This third lecture in section 2, we're going to talk about high blood pressure, hypertension. We started with neurotransmission and autonomic pharmacology. It's a great place to start before going into high blood pressure or hypertension. So make sure you have a handle on those things because this is going to take this in a different direction. Let's talk about the blood pressure. All right, so as blood is pumped through the arteries, it creates pressure within the walls of the arteries. And we don't measure that directly, we measure that indirectly, but we know inside of the arteries, the pressure within the arteries, pressure against that wall will change. And so this is my cartoon. As the heart beats, as it squeezes and becomes smaller, it pumps into the arteries, making them a little bit bigger. That's arterial compliance. So this is a slice through my artery, and as the blood flows through it, the artery gets a little bit bigger, just like a garden hose. When the water flows through the garden hose, it gets a little bigger, all right? So again, as blood is pumped through the arteries, it creates pressure within the walls of the artery, and that's what those arrows are supposed to show you. As the heart beats and contracts, the pressure inside of the arteries goes up. All right, so as the heart contracts, that increased pressure is called the systolic pressure, the system pressure. So notice that when the heart beats, the pressure goes up. So as the heart contracts, this increased pressure is called the systolic pressure. The systolic pressure is always the higher pressure. Occasionally I'll meet somebody and they'll say, my diastolic was higher than my systolic. No, the systolic will always be the higher number, and it is the higher number that results from heart contraction. So the heart contraction results in increased pressure. That's the systolic pressure. All right, well, as the heart relaxes, the arterial pressure does not go to zero, not unless somebody's in really bad shape. If they have very poor mean arterial pressure, their diastolic pressure might be as close to zero as we can stand. But the truth is, the diastolic pressure is not zero. There is pressure inside of the heart, and there's pressure inside of those arteries even as the heart is relaxing and filling, and that's called diastolic pressure. That's the lesser of the two numbers. The diastolic pressure is always the lower number, and that diastolic pressure occurs because the heart is relaxing and there's not as much pressure on the inside of the walls of the arteries. And if you go to my YouTube channel and find Heart Sounds, there's a playlist called Heart Sounds. The current version of YouTube, they sound really good. Take a look at the Heart Sounds videos, and they'll show you where the murmurs come from. Be sure and wear headphones, and better yet, if you take your stethoscope and put it against the headphone, then you will realize that I did spend an enormous amount of time on a Fruity Loop synthesizer making those. But me in the music business, that's a different story. But we need the systolic and diastolic pressure to function properly for our valves to function properly. All right, enough of that. Blood pressure is written as a fraction, but it's not a mathematical fraction. They might as well use a dash or a period or an asterisk. All right. So blood pressure is written as systolic over diastolic millimeters of mercury. Somebody the other day told me this was hemoglobin. I'm like, no, Hg is on the periodic table that we showed you for 1.1 biochemistry. And we use a mercury column in the old days to measure pressure. Now mercury is toxic and expensive, so we don't use it in blood pressure sphygmomanometers anymore. And the normal we'll consider to be 120 over 80 millimeters of mercury, meaning 120 systolic, 80 diastolic millimeters of mercury. All right, now I've been fooling everybody with this quiz question for a long time. Anything around 120 over 80 is normal. 122 over 78. 118 over 76. As long as they don't have orthostatic hypotension, as long as they can go from laying down to standing up or even exercising, if they're asymptomatic, doesn't matter how low their pressure is, it's when they start having symptoms from low pressure. They start to feel lightheaded, like they're going to pass out, or when they go from sitting to standing. So those low pressures are abnormal if they're symptomatic. However, a normal blood pressure is anywhere around 120 over 80, and so the correct answer on the quiz is all of the above. All of you go looking for 120 over 80, and you click that as normal, and if you look carefully, all the other ones are normal as well, And I bet that you never meet any single person whose blood pressure is exactly 120 over 80 every time, I assure you. All right, so be careful with that word normal. We talked about that during medical terminology. So there is a trick question that which one is normal? They're all normal. All right, blood pressure is vital to life. That means if something is 0, that is a sign of death. That's why it bothers me to hear pain as a vital sign. Oh, pain is, controlling pain is vital. But pain of 0 does not equal death. Therefore, pain is not really a vital sign. Vital sign means equals to 0 equals death. And so a blood pressure of 0 is a sign of death. That's why it's called a vital sign, and it's important for people like me to know what their blood pressure is when you're calling me about some kind of problem, or when you're a nurse calling some other doctor with some kind of problem. I can assure you that they're going to want to know the patient's vital signs, and that includes their blood pressure. And so many countless times over the decade that I was a hospitalist in Ohio, the phone would ring in the middle of the night from somebody calling me about some patient that I was covering for some other doctor. And they'd say, "Oh, Dr. Farmer, I'm calling about some other doctor's patient." And I'm like, "Oh, wow, well, what are their vital signs?" And the nurse would be like, "Let me put you on hold." And then I'd be on hold, and then the phone would click, and then I'd call back, and nobody had any idea who was calling me. All right, so it's vital that you have this information in front of you when you call somebody to intervene on this. All right. So take a blood pressure. Now, in the old days, there's the mercury column. How high the mercury column went was equivalent to how much blood pressure they had. And so that's why we measure blood pressure in millimeters of mercury. But now we use more modern machines. And they'll show you how to do this when you go to real healthcare school. You put the cuff on, and you put it on properly. There's instructions on the cuff. And you'll put your stethoscope over the brachial artery. Yeah, you can feel it. It's on the median side of things. And you put your stethoscope there. You close the valve on the inflator bulb, and you start to squeeze it up. And so now we don't use mercury. We use a dial that mimics the mercury column. And so we'll pump it up, and as we pump it up, we can see the pressure go up, and you get it up to a certain amount. And you start to listen. You let it out really slowly, and then you listen for a whooshing noise, Karate cough sounds. Whoosh, 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 whoosh. And so where the Karate cough sound starts, and in that case it was 120, and where it ends was 80, and so that's generally where that comes from. It's actually slightly more complicated than that, but that's not really what they teach. And so I wanted you to be aware of those brewy sounds. They're called Karate cough sounds. I think I have them on my slide. There we go. And so if you really want to know a lot about blood pressure sounds and how they are misinterpreted by people who are experts, understand the Karate cough sounds. And then arterial disease affects the Karate cough sounds as well. And so the systolic pressure, as we let the pressure off, you'll notice we have silence. And then at 120, we had this tapping sound. I wasn't very good at tapping. And then it'll soft swishing, and then it'll be a crisp sound. Then you'll hear this blowing sound. And then where we have silence in between 4 and 5, that's where they put the diastolic pressure. Other people with the diastolic pressure somewhere else. If these aren't in your slides, be sure and Google the Karate cough sounds and know what they are, because pulmonary compliance affects phase 4 and phase 5 Karate cough sounds. But we generally don't teach it like that. We teach it like this. Pump it up while you're listening. And then slowly let the air out of the cuff. And listen. You'll hear. Whoosh, 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 whoosh. So where it starts, making that brewy sound, that Karate cough sound, that's what our pressure is on the systolic side, and where it stops is our pressure on the diastolic side. And that's measuring it indirectly with a blood pressure cuff because we can't stick a catheter inside of their arteries and measure directly every time. Hypertension is high blood pressure. That's abbreviated HTN. Why isn't anybody teaching people that HTN is the abbreviation for high blood pressure? Somebody asked me that. Like, well, there it is on the slides. I'm not going to make it flash great big, but HTN is the abbreviation for high blood pressure, and it is a disease process that's characterized, clinically manifested by consistent, here is a very important word, consistent elevations in blood pressure. Look, if I go running around the block, my blood pressure will be higher than 140/90, but it doesn't matter what it is once after exercise. What matters is consistent at rest. And so that's why they'll give you specific instructions. Have them seated on the ground and relaxed with both feet on the ground. Another important thing is to make sure that that blood pressure cuff is not in the dependent position. That cuff should not be below the level of the heart. The cuff should be at the level of the heart. And so if they're relaxed and seated and they have a consistent elevation in blood pressure at the level of heart greater than 140/90, then we're going to consider that hypertension. Some people, their high number is high, and we'll call that systolic hypertension. Sometimes the bottom number is high. We'll call that diastolic hypertension or diastolic dysfunction. But most of the time you see high blood pressure, it's both. And for this course and for clinical pharmacology, it doesn't matter. Over 140/90 is hypertension. All right, well, this is what's very important about high blood pressure. One of the problems with high blood pressure, the problem with high blood pressure, is somebody goes to the doctor's office, maybe they have, a cut on their arm, or maybe they need a refill of some medication, and we take their blood pressure and it's high, and then we take it again and it's high, and then we take it again and it's high, and we say, hey, your blood pressure's been running really high lately. We need to start doing something about that. No, that's not what they're there for. They're there for something else. And then they find out when you start taking care of them for high blood pressure, oh, the doctor wants all these tests and take all these pills, and oh my gosh, why would anyone want to do that other than profiteering? And so then we have all sorts of people dying from the effects of high blood pressure. And the reason is this right here. Chronic uncontrolled high blood pressure is going to damage blood vessels, and you can think of any organ that relies on its blood vessels, and think about what happens when that organ stops working. So hypertension is a leading cause of brain death and myocardial infarction and stroke and all sorts, and blindness and kidney disease and dialysis. So there's all sorts of problems that emerge from high blood pressure. And the problem with high blood pressure, essential hypertension, primary hypertension, is that there's several different causes that all work together that conspire against the body. That means it requires a lot of different treatments. It requires several different medications, more than one medication, and requires tests to make sure that the heart's okay and the eyes are okay. All right. All right, well, here's a funny word, essential. Essential doesn't mean we need it. Essential means essentially they're not really sure what the exact cause is, and it's multifactorial. There are several systems in your body that regulate blood pressure, and they go out of balance together, causing essential hypertension. Again, essential hypertension is the most common form of high blood pressure, and its cause is multifactorial. People who have a family history of high blood pressure are at higher risk for having high blood pressure. Males are at higher risk for developing high blood pressure, hypertension than women. African Americans have the highest risk for essential hypertension than people of brown skin. Caucasians have the least risk of the three for hypertension. However, all ethnicities have a very high risk of essential hypertension, and the lethality, the morbidity and mortality for lack of treatment remains the same. So there's plenty of high blood pressure for everybody, regardless of your family history, gender, or ethnicity. All right. We just like to say this, all right, but there's so much of this in anybody. You can have high blood pressure with no family history. You could be hypertensive and female. You can be any ethnicity and have severe hypertension. Eating too much salt can raise blood pressure. Stress raises blood pressure. Lack of exercise raises blood pressure. Smoking is bad for everything. That can raise blood pressure as well. And so there's plenty of people out there that have a family history of high blood pressure. Maybe they're male, African American, they're stressed out, they eat too much salt, they don't exercise and smoke, and all these factors multiply with each other. And there's plenty of people out there that smoke and don't exercise, are all stressed out and eat too much salt regardless of their family history, gender, or ethnicity. All right, so the bottom line is hypertension is killing people out there. And the reason they don't really want to do anything about it because they have to take pills and do all these tests, and yet they don't feel anything. So it makes it really difficult to explain to our patients why they have to treat their hypertension and treat it effectively, because we really don't have time to go through 100 PowerPoint slides with them. There's this thing called secondary hypertension. That's not what we're talking about today. Secondary hypertension has a specific cause for the elevated blood pressure. So people who have kidney disease, if they have some kind of renal artery stenosis and their kidney's not getting enough blood, then it can send off signals raising blood pressure. Pheochromocytoma is a tumor of not only the adrenal medulla, which we did talk about, but its related organs, the Zucker candles. And when there's tumors in those that release too much epinephrine, that's called a pheochromocytoma. We test for the pheochromocytomas by taking a 24-hour urine and looking for homovanillic acid and vanillyl mandelic acid, and we talked about that during neurotransmission. We'll talk about Cushing's disease and Cushing's syndrome. Those are both reasons for secondary hypertension. We'll talk about that in endocrinology. Cushing's exposure to too much glucocorticoid, whether internally or externally for whatever reason. Pregnancy can result in hypertension. I don't even think they call that secondary hypertension. They might call that something else. I get an email when I flub that. Vascular anomalies. I took care of a young lady who had aortic arch stenosis, and it caused secondary hypertension, at least on one side of her body. Neurologic disease, of course, can result in secondary hypertension, and none of that's what we're talking about. Today we're talking about essential hypertension, which is multifactorial without a specific cause. And so that's why I go through this, because there's not just one type of high blood pressure. All right, and so hypertension usually has no symptoms. That's why we have a hard time convincing people to get EKGs and chest x-rays and go visit the eye doctor. It's hard enough to do anything around here. Now we got to see a bunch of doctors over something that has no symptoms. So it's really difficult to get people to be compliant to take care of their high blood pressure. And so we'll find it on a routine visit to a medical clinic. They'll go to the clinic for one reason and probably not get that, but they'll get a whole earful about hypertension. And so, you know, it is a source of friction with our patients, and that's why it's so hard to treat. However, hypertension can cause symptoms. Headache and visual changes are the most common, especially during stress, anger. You know, when I march upstairs, I get a headache. Or I got real angry the other day, and I got a headache, and the vision in my eyes changed. Those are the sorts of stories that we hear when somebody's symptomatic from high blood pressure. And so be on the lookout for that, because this tells us that they are suffering from the symptoms of hypertension. All right, well, hypertension is all sorts of strange words that don't seem to make any sense, and this is one of them, malignant hypertension. Everywhere, there's only a couple places, and I can't think of them right now, but everywhere else, malignant means cancer. And so when we use the word malignant, we're talking about cancer, not in this case. Malignant has nothing to do with cancer, because malignant means organ damage. Technically, malignant means organ damage. And so there's a few things out there like malignant hypertension. That means the blood pressure is so high it's causing organ damage, not cancer. All right, so please don't associate malignant hypertension with cancer, because that'll be a board question. That's a favorite trick question. What kind of cancer causes malignant hypertension? And be sure and choose pheochromocytoma, because that is a cancer that can cause malignant hypertension. But again, malignant in this case has nothing to do with cancer. It has to do with organ damage. And so when hypertension is severe enough to cause acute visual, neurologic, or other organ damage, it's called malignant hypertension. So I was working, this is my favorite story to tell about this because it was the most obvious case. I was working out towards the resorts in an urgent care when I used to fill in and do that sort of thing. And a young African-American woman is being wheeled to the clinic by the concierge, and she is acting like she is completely and totally drunk. Now, be careful about assuming that everyone who behaves like they're drunk is drunk, because that is a big mistake in medicine. The main problem with her being drunk is it's Tuesday morning at 10 o'clock in the morning. That's not usually when inebriated people show up. And she did not smell like alcohol, like she was drunk. She did not smell like ketones. Her breath didn't smell like fingernail polish, as we see in people who have diabetic ketoacidosis. So she wasn't breathing any drunken or ketoacidosis smells. And so the very first thing we're going to do is what? Get vital signs. That's going to be the first thing you do anyway, because that information is vital. We get her blood pressure. Her blood pressure is 250 over 180, 150, something like that. Ridiculously high. I think the highest blood pressure I've ever seen in a highest blood pressure I've ever seen. I mean, how high a blood pressure can you see in a living person? So anyway, her blood pressure was really high, and she was like acting like she was completely drunk. She could barely speak. She was slurring her speech. She was slurring the gibberish coming out of her mouth. So what we did for her, we'll talk about this when we talk about vasodilators and coronary artery disease. We used a nitroglycerin tablet. It went under her tongue, and as soon as that nitroglycerin kicks in, the nitroglycerin works really quickly. Nitroglycerin lowers blood pressure, lowers really quickly. And she just woke up, and all of a sudden she's like, where am I? What happened? And so she was having malignant hypertension. She was having neurologic injury because her blood pressure was so high. And so we took her blood pressure. We gave her a nitroglycerin tablet. She went to the emergency room in an ambulance. They checked her out, and she was doing just fine. She came to Hawaii on vacation, and she forgot to bring her beta blockers, her blood pressure medication. And abruptly stopping high blood pressure medication can cause it to go sky high and have this happen. And so she checked out just fine in the emergency room. They gave her a prescription for her beta blocker, and she went on and had a great vacation in Hawaii. All right. But that's not always the case. Sometimes this organ damage is permanent, causing all sorts of catastrophic results. And people can have catastrophic results even if they're asymptomatic the entire time. They don't have to have this, okay? So we talked about symptoms, headaches, visual changes. We talked about severe symptoms like they're behaving like they're either having a stroke or they're drunk, not cancer. Right. But this is the real problem. High blood pressure has no symptoms. We detect on an office visit. People won't do what they need to do. They'll have high blood pressure for a long time, and then they have some kind of sudden catastrophic event. And so we got to convince these people to take care of their blood pressure, because blood pressure damages blood vessels. All right, so as blood vessels exposed to high blood pressure become thickened and hardened, they make them less flexible. All right, so here's my normal artery, and then after years, usually about a decade of high blood pressure, the scar tissue forms on the outside of the blood vessel, makes it narrower, takes out its capacity to stretch its capacitance, and so it interferes with its functioning. That endothelial lining that's on the inside of the blood vessel is essential to all sorts of regulatory processes, and it's separated by scar tissue. And so this is arteriosclerosis. The plaques that are formed are called atherosclerosis, and so again, here's atherosclerosis. There's inside of my normal artery, and then the atherosclerosis is this gunky stuff that forms inside. And when we get to 2.5, we'll talk about this endothelial lining on the atherosclerotic plaque breaking off, ulcerating, causing blood clots, resulting in stroke and myocardial infarction. Something you should know is that atherosclerosis and arteriosclerosis. Those two terms are thrown around in the medical community like they mean the same thing, and that's fine when you go be part of the medical community. You can use words as well, but technically arteriosclerosis is the scarring that interferes with the arterial function. The atherosclerosis is this gunky buildup that goes inside of the artery, not only narrowing it, but that can ulcerate and cause blood clotting. So I want you to know that there is a difference between atherosclerosis and arteriosclerosis. Now, believe me, there are plenty of arteries that have plenty of both. You can look at an artery if you're in that sort of situation and say that they have both atherosclerosis and arteriosclerosis, but I want you to remember those are separate things and know the difference, please. All right, so the narrow arteries become blocked and the blood supply to an organ is stopped, and the organ damage is called infarction. So infarction is permanent damage that's caused by a lack of blood supply. So myocardial infarction is myo, muscle, cardio, heart. So myocardial infarction is a heart attack. I want you to know this: ischemia is reversible. And so I was looking at some book the other day. They didn't know the difference between these two words, so I'll tell you right now. Infarction is permanent. Ischemia is reversible. And so when we talk about an ischemic event, if we restore the blood supply, the damage will be reversed. And that'll be important as we go through and talk about stroke and myocardial infarction and myocardial ischemia. All right, so hypertension is the major cause of stroke. We used to call it cerebrovascular accident, and we still do. I still see the CVA word used all the time, but there was a Lancet article, late 90s, early 2000, that said, please quit calling things that we can prevent an accident. And so there was this big push in medicine to quit calling disease processes an accident if they were preventable. And so you'll see the word cerebrovascular accident used. We'll hear the word cerebral infarction, cerebral like your brain, infarction as in cell death. All right. Sometimes they use the word brain attack. I think that's not quite the right term. In old times, the old doctors, they used to call it apoplexy, and apoplexy not only meant stroke, but it could mean seizure as well. So if you're reading something old, something foreign, something from one of us old guys, maybe they'll call stroke apoplexy. All right. So now there's all sorts of medical words to describe the word stroke because cerebrovascular accident wasn't good enough because of that accident word right there. All right. And again, that's how lots and lots of words come to mean the same thing. All right, so hypertension can cause brain damage. It can cause stroke. It can cause somebody to be severely impaired and live a long time in really bad condition, unable to care for themselves if it doesn't kill them. And so here's a clogged artery, and we can see this color change in the brain. We've had a stroke. That's a cerebral infarction, and they've had it a very eloquent place in their brain. That's really bad. However, the high blood pressure can be high enough to cause a brain bleed in the brain. And usually these fine arteries right here off the cerebral artery that go into the basal ganglia. They're very, very sensitive arteries to pressure, and so this is the most likely place to have cerebral hemorrhage, bleeding in the brain. And again, that can cause death if it doesn't leave them incapacitated for the rest of their life. Right? Something else can happen is an aneurysm. An aneurysm is the pressure, the outside of the artery kind of breaks loose a little bit and the inside starts to bubble out. Sometimes we see this on tires, not so much lately. But anyway, when the high pressure goes through the arterial wall, there's a part that can push through, start to balloon. That balloon gets big enough to where it pops and causes them to bleed. Aneurysms can occur for other reasons. There are people who inherit their aneurysms. However, high blood pressure makes them worse. If people have aneurysms, we'll be very interested in, they'll be compelled to manage their blood pressure because regardless of the cause of the aneurysm, high blood pressure is only going to make it worse. Aneurysms can pretty much occur everywhere. There are a couple of arteries out there that don't get aneurysms. However, the aortic aneurysm, the aorta, is the most common place, and then the brain, somewhere in the brain, cerebrovascular aneurysms. They are the second most common, and if they're not the second most common, they are certainly the most debilitating, the cerebrovascular aneurysms, the brain aneurysms. So aortic aneurysm, cerebrovascular aneurysms, this is the two most common places to discuss aneurysms. And so this high blood pressure can cause all sorts of brain damage. The person goes to the doctor, their blood pressure's been running high, they say they feel fine, and then one day they have a stroke and they have a brain bleed, and they die. And it's really unfortunate. You know, we know people like that in our community, and they just seem healthy one day, and then they die instantly, and we find out they had uncontrolled hypertension. And it's sad because, you know, we wish we had 100 slides to impress upon them the need to treat their high blood pressure. And then there's a whole contingent of people out there that say, oh, pills are bad. We're just poisoning the environment with pills, so don't take your pills. And then they don't take their pills, and then one day they die. And guess what? Their story is not available unless I'm telling it. All right. So I notice in church there's all sorts of people who quit taking their pills and they feel better, maybe temporarily. However, there's all sorts of people out there who quit taking their pills and they die. And I spent my time as the county coroner learning their stories as well. So it's very important that we take care of high blood pressure in a very effective manner because it damages all sorts of blood vessels, especially the eyes. And so if we go to the eye doctor, hopefully our retinas look like this. However, high blood pressure can damage the eyes. And if you go to the doctor, maybe they'll talk about flame hemorrhages and exudates and cotton wool spots. I don't need you to know that. I need you to know that high blood pressure damages the eyes. And so when we have somebody who has uncontrolled hypertension, we want them to go see the eye doctor. Why? For this reason right here. Because hypertension can cause blindness. And first, those changes can occur without them even noticing. And then they can essentially stroke in their eyeballs and be blind. Same thing with kidneys. The kidneys can develop arterial sclerosis in the arterioles that feed the glomerulus. And it's one of the leading causes of kidney damage and the need for dialysis. All right? So a lot of people on dialysis, the external kidney machine, they're suffering because of uncontrolled high blood pressure. And, you know, those people, you don't hear them talking about, you hear them talking about how important it is to control high blood pressure. Right, because hypertension damages the blood vessel, it's going to damage the heart too in several ways, either infarction, hypertrophy, cardiomyopathy. And so here is somebody's cartoon of the heart, and already we see this aortic aneurysm in their arch. That's a real bad place. My best friend died of an aneurysm right at the aortic root, just instantaneously. Because one day he wasn't controlling his blood pressure the way he was supposed to. I think somebody convinced him to stop taking his pills, and his little aneurysm right there popped, and he died instantly. All right, so here we've taken a slice through the myocardium so we can see it. And myocardial infarction is a place where the blood vessels has been blocked, supplying that muscle, and now we have some cell death in that area, and maybe it's not enough myocardial infarction to cause them problems. We have friends that have had myocardial infarctions and they have little dead places on their hearts and they recovered and they do just fine. But sometimes the dead places on their hearts are great big and incompatible with life. And so myocardial infarction causes death because we've killed off so much of the heart muscle it can't beat. And many times this is due to high blood pressure. There's other causes, but they all mix together and multiply each other. It's very important to control high blood pressure. All right, ventricular hypertrophy. We'll talk about this when we talk about congestive heart failure. When you use muscles, the muscles get bigger, and if you're a weightlifter trying to make your arms bigger or win championships for weightlifting, great. Hypertrophy, growth of the muscles, is a good thing. The problem is it's not a good thing in the heart. And so people with high blood pressure, they'll have ventricular hypertrophy, thickening the wall of the heart and make the heart wider. We'll look for this on chest x-ray. I wish I had that chest x-ray. We'd look at the width of the heart compared to the entire thorax. And if the width of the heart takes up more than 50% of the width of the thorax, we consider that ventricular hypertrophy, or we consider that cardiac hypertrophy. And so people with high blood pressure, their hearts will get bigger and they'll take up more space on the chest x-ray. And so then there's evidence that their blood pressure has been too high for a very long time because of that ventricular hypertrophy, that cardiomegaly, the big heart that we see on chest x-ray. That didn't happen overnight. It took a long time. That took years for that to develop. If we can control their blood pressure the near entirety of time, we can control the big heart, the cardiomegaly, the ventricular hypertrophy. If it goes uncontrolled, this ventricular hypertrophy interferes with filling and pumping. This can lead to congestive heart failure. Sometimes the high blood pressure will stretch the heart out so much the heart can't function. Cardiomyopathy, disease of the heart muscle. Here it's called dilated because it's opened up the chambers of the heart. Kidneys play an important role in the long-term regulation of blood pressure. So when we talked about the sympathetic nervous system, remember this gives us immediate control over the sympathetic nervous system. This gives us immediate control over over our blood pressure. And so when the adrenaline kicks in, our blood pressure goes up really quickly, and then when that wears off, our blood pressure goes down again. So again, the sympathetic nervous system, the adrenergic nervous system gives us immediate control over our blood pressure, but long-term control is partially regulated by the kidneys. So if you did not know this, the kidneys regulate the balance of salt and water in the body. That's the easy explanation. When we come back, we'll make things more complicated than that. And the kidneys get rid of things that we don't want either. The kidneys are made up of these little things called nephrons. We'll talk about that next time as well. And what can and not pass through the filters. The next lecture covers that very well. Many substances like glucose will be reabsorbed by the body unless they're diabetic. Diabetic will take the glucose and that high level of glucose will function as an osmotic diuretic. We'll come back to that too. All right, so kidneys regulate something called blood volume. If you're in the clinical setting talking about anything cardiovascular, volume is not the radio volume. Volume is quite simply the volume of blood. So if they're hypovolemic, then they have low blood volume. So when the blood volume decreases, the kidneys will send out signals so the body retains salt and water. When the blood pressure is up, the kidneys will send out signals to get rid of salt and water. And that's done with the renal hormones. And so there's mesangial cells that constantly sense the pressure. And when the pressure is too low, they will secrete something called renin. So renin is actually our first foray into renal endocrinology. Even though they don't talk about renin, angiotensin aldosterone system as being endocrine, it is. Because here's a renal hormone being secreted in the blood supply to communicate with other organs. So renin is the kidneys' cry for help saying, hey, wait a minute, I am not being perfused properly. And so this renin goes out and causes this chain reaction, converts angiotensinogen to angiotensin 1. Somebody thinks you need to know that. What I want you to know is renin increases angiotensin 2, and this angiotensin 2 is a very powerful vasoconstrictor, and this increases blood pressure. And so one of the natural systems in your body to raise blood pressure is angiotensin 2. So now again we have the sympathetic nervous system raising blood pressure, and then in the long term the kidneys can regulate blood pressure as well because the kidneys release renin, and that causes a cascade reaction that raises angiotensin 2 levels. And angiotensin is a vasoconstrictor, and things that are vasoconstrictors raise blood pressure. So that's why we'll block the conversion of angiotensin 2, or maybe we will use angiotensin 2 blockers to decrease blood pressure. Right. Something angiotensin 2 does, not only does it stimulate, not only does it cause vasoconstriction, but it causes the adrenal cortex to produce aldosterone, and aldosterone will cause us to retain salt, and by retaining salt, we'll retain water, so we can increase blood volume as well. So what does renin do? Renin is the kidney's cry for help to increase volume. Angiotensin II, vasoconstrictor, but angiotensin II also stimulates aldosterone to retain salt. And that's why you'll hear this called RAS. I think they call that RAS or something. It's the renin-angiotensin-aldosterone system. It's not too hard to pronounce that. Okay. And again, aldosterone is going to work on the kidneys to retain salt and water. We'll talk about aldosterone plenty when we get to endocrinology. All right, so we spent a lot of time talking about the adrenal medulla, which makes adrenaline when we're talking about the adrenergic nervous system. And notice, even though it's two organs in one, here's aldosterone. It's a mineral corticoid made by the adrenal cortex, and it too has some regulation over blood pressure as well. So we'll get into that when we get into endocrinology. Something else that your body does is your brain can control volume with something called antidiuretic hormone. You might know that as vasopressin. That comes from the posterior pituitary, and its response to low blood pressure. It asks the kidneys to retain water. This is what causes the kidneys to retain water. If you don't have antidiuretic hormone, your kidneys will just lose free water in a lethal manner. So we need antidiuretic hormone to maintain body water, and then the brain changes the level of antidiuretic hormone depending on the amount of water we need to retain. And so now we've talked about renin, angiotensin II, aldosterone, antidiuretic hormone. All of these things are involved in the regulation of blood pressure. And so that's what this picture is for. Your brain's involved, your heart's involved, your kidneys are involved, your adrenal glands are involved. Right? And all these things work together for harmony, and then something falls out of place, and then they all start working against you. And that is the reason that it's hard to control blood pressure with just one medication. We can start with monotherapy, but most people who are controlled have difficult to control high blood pressure. They have to take more than just one medication. They might need to take 2 or 3, because a little bit of different classes of medication are going to do more than a lot of one medication. And so that makes it more difficult. We find somebody with high blood pressure. We want to treat them with more than one medication, and we want them to get a chest x-ray and an EKG and a visit to the eye doctor and all this blood work. And they're like, well, I came in because, I had a toenail infection. So it makes no sense to them. And again, we don't have time to spend 15 seconds with them explaining things. We certainly don't have an hour and a half and 100 PowerPoint slides to explain it. And so that's why each time we see them, when they come repeatedly to the office, we have a little bit more to tell of their story. And with COVID lately, it's made it much more difficult. The first thing I want you to do is memorize this right here. Can you name the 7 classes of drugs that I use to describe antihypertensives? Now, if you look at some other book, they might have 9 classes. Some of them might compress them and say there's 5. This is what I want you to know. The beta blockers, the alpha blockers, those are the peripheral sympatholytics we talked about. And then there's central alpha agonists. That central word means it works on the brain. Now, we went through autonomic pharmacology. We talked about blockers in terms of blocking the receptors on the end organs, all right? So when we talk about alpha blockers, we're blocking the receptors on the end organs. When we talk about central alpha agonists, we're talking about something that's working inside of the brain, and so you'll notice the opposite. Alpha blockers, alpha agonists. Well, the alpha agonists go inside the brain and work, and we'll talk about that. One of the most important things in antihypertensives is the use of hydrochlorothiazide. ACE inhibitors as well. ACE inhibitors will be listed as antihypertensives, but ACE inhibitors have all sorts of uses that have nothing to do with high blood pressure, and so that's why I want you to be really careful when you start looking at these reference books, and they'll say, oh, ACE inhibitors are an antihypertensive. And that's fine, but sometimes we prescribe ACE inhibitors for other reasons, like to protect the kidneys from the ravages of diabetes mellitus, a disorder of glucose regulation. And the person will say, oh, we put them on this ACE inhibitor to protect their kidneys, and then they go out and they read, well, ACE inhibitors are antihypertensive. I don't have high blood pressure. What are they thinking? So again, we have to be very careful about this word, the therapeutic class, because ACE inhibitors are therapeutically antihypertensives. But my problem with this nominal nomenclature is that ACE inhibitors have a lot of uses that have nothing to do with high blood pressure, and we should talk about that as we go along. ARBs are angiotensin 2 receptor blockers. Remember, angiotensin 2 is our vasoconstrictor, and so by preventing its conversion through the use of angiotensin converting enzyme inhibitors, we can prevent the production of angiotensin 2, or we can block the receptors, angiotensin receptor blockers, or angiotensin 2 receptor blockers. And then calcium is essential for muscle contraction, whether it's striated muscle or smooth muscle. And so myocardium responds to calcium channel blockers by relaxing a little bit, so we can lower blood pressure that way as well, because blood vessels relax with calcium channel blockers as well. But there's more to all this than lowering blood pressure. There's also increasing lifespan, increasing quality of life, and life expectancy. And so you'll hear these different classes of drugs thrown around as far as, well, it's one thing to lower the numbers, but it's a different thing to increase life expectancy. And so if you pay careful attention, you'll notice that debate going on. We'll start with the beta blockers. The beta blockers were our sympatholytic drugs that we talked about in autonomic pharmacology. And we're going to divide the beta blockers into cardioselective and non-cardioselective. All right, so we'll start with cardioselective here. The cardioselectives are going to affect beta 1 and beta 2 receptors the same, or pretty much the same. And so a non-cardioselective beta blocker, sure, it can lower blood pressure, but it's also going to interfere with lungs. And so we can have bronchospasm with that. And then it can affect our glucose regulation as well. And if you read in the fine print, people who take beta blockers need to be on the lookout for their effects of glucose regulation. And so again, the non-cardioselective beta blockers are not selective for the heart, so they have more bronchospasm. All right, well, this leaves us believing that cardioselective works only on the heart. That is not true at all. And occasionally we'll see people who believe that. It's not true. Cardioselective beta blockers are not completely selective for the heart. There is some effect on bronchospasm, and when people argue with me, I have them look at the FDA monograph, and the cardioselective beta blocker will say, please avoid in people with asthma and chronic obstructive pulmonary disease. We'll even put cardioselective beta blockers in the eye drops of somebody with glaucoma. Sure, the beta blockers prevent fluid production in the eye and increase drainage, lowering the pressure inside of the eye. But we'll use cardioselective beta blockers that don't have anything to do with the heart. We'll put cardioselective beta blockers in the eyes quite simply because of this right here. They have less bronchospasm. And so if somebody has glaucoma and chronic obstructive pulmonary disease, maybe we'll want to use a cardioselective beta blocker. Maybe we'll want to use something else entirely. Okay. So when you are looking at the beta blockers, we're going to divide them up into two sections, cardioselective and non-selective. Propranolol is the non-selective one, so the first thing I want you to do when you see propranolol, I want you to go look this up on the Daily Med website. Go find the FDA monograph and just take a quick look. Take a quick look in the syllabus about what I want you guys to look at as you're going through the information, because there's no way I'm going to cover all that on TV in one day. So take a look at the package insert, the label for propranolol. I don't need you to look up all the beta blockers. There's a big list in your clinical discussion section if you want to see the big list, and it's even bigger than that. But what I want you to see is if you're really compulsive about looking them all up, you're going to notice they all read the same. All the non-cardioselective beta blockers are going to read just like propranolol, Inderal. If you read the package label, they're all going to read just like that. And so there are all sorts of different non-cardioselective beta blockers, and the manufacturer can say there's all sorts of uses. But if you just look at the package label, what I want you to see is the non-cardioselective beta blockers are all going to read just like propranolol. And so if you read the Katzung book that goes with this course, that's optional. That's one thing they say is don't memorize these long lists of drugs. Pick one drug that is the prototype for its class, like propranolol, is our typical non-selective beta blocker. And if you take a little bit of a look at propranolol and the package insert, you'll realize that all the non-cardioselective beta blockers read the same way. Atenolol, tenormin, is one of the cardioselective beta blockers. Again, if you look up atenolol, tenormin, you'll see that it's not entirely cardioselective, that people with chronic obstructive pulmonary disease need to avoid these types of beta blockers whenever possible. Not in my notes. This is for those of you who want extra brownie points through email. I would suggest that there's one more, and they would be called, I just had it on the tip of my tongue. I'll be back to it. Intrinsic sympathomimetic beta blockers. Intrinsically sympathomimetic. What does that mean? That means at really high doses, they quit blocking and they stimulate a little bit. So those are great with cardiac rhythm and to prevent people who need lots of beta blockers from getting overdosed with them. And so, but I don't talk about that because that's much more for cardiologists to argue with me about and tell me I'm wrong. And so I want you guys to know non-cardioselective and cardioselective. And then if you really want to step it up a notch, there's one more group that is the intrinsic sympathomimetics. And so I only bring that up because if you look at the cardioselective beta blockers that are not intrinsically sympathomimetic, their FDA labels will all read exactly the same. Okay, so that's what I want you to see as we go through the drugs. It's the similarities within the class. And it's not what color the pill is. It's not Teva Pharmaceuticals. It's certainly not its NDC number. What I want you to know about altenolol is what we talked about in the syllabus. What is its indications? What are its uses? What are its effects? What are its other effects that we need to be looking for? What are the warnings? What is the treatment for overdose? I want you to be able to look up everything that you see because that's what's going to teach you pharmacology, not this guy right here, okay? He's not going to teach you pharmacology. Looking this stuff up is what's going to teach you pharmacology on the professional level. I'm just trying to get you off to a good start. Let's talk about the alpha blockers. I remember beta blockers, beta 1 receptors are in the heart. Alpha 1 receptors are on the blood vessels. And so we can use sympatholytics like Cardura, doxazosin, as an antihypertensive. But again, the alpha blockers are notorious for orthostatic hypotension. That's when blood pressure falls out from the patient when they go from sitting to standing. So we have to be very careful about using these in patients, especially for the first time. So we're going to start with the lowest dose possible and make sure they're very careful when they go from sitting to standing. Because alpha blockers can cause orthostatic hypotension, so always start with the lowest dose and tell patients that go from lying to standing to do it very gently and very slowly until their body gets used to the medication. Once they get used to the medication, this isn't such a big deal. However, alpha blockers can cause orthostatic hypotension. And don't be fooled. They say, oh, well, after time, that's not such a problem. Yeah, until they go out one day and sweat and they become hypovolemic, and then the orthostatic hypotension can come back due to the alpha blockers. All right, so alpha blockers lower blood pressure. All right, well, that's blocking alpha receptors on the blood vessel. That's peripheral alpha blockade. And so that is sympatholytic when we're blocking the receptors on the blood vessel itself. All right, well, central alpha agonists are very interesting. What they do is they stimulate receptors in the brain, convincing the brain that the body is releasing too much epinephrine. And so this is the story that goes with this. It's an alpha agonist. All right, so all sorts of decongestants for colds are sympathomimetic alpha agonists. And so the people who discovered centrally acting alpha agonists thought that they were inventing a peripheral alpha agonist. And so they were testing this in animals, and they gave them the alpha agonist, and exactly what happened is what they expected to happen. The blood pressure goes up while the drug is being absorbed in systemic circulation, and this can cause headache and other problems. And then the drug gets into the brain, and the blood pressure drops quickly, and that's what happened with the first central alpha agonist. They watched the blood pressure go up, and they thought, oh, hooray, we've invented a new alpha agonist, and then the blood pressure dropped really bad, and they're like, oh, no, this is a big mistake. And what they discovered were central alpha agonists. And it was interesting. I was hearing somebody tell me a story the other day, and they take central alpha agonists for their blood pressure. And they said, oh, well, you know, I took my medication and then my blood pressure, it just goes up. And then I realized when I ate such and such, my blood pressure dropped quickly. And I would suggest to you that the centrally acting alpha agonist story is when it is being delivered to the brain from the peripheral blood supply. Our first thing that we see is the blood pressure to go up, and that is what we saw with the original research animals. And then when this drug crosses the blood-brain barrier and goes to the pressure or the epinephrine sensors, the alpha-2 receptors in the brain, they sense that the body is raising epinephrine levels, and the brain cuts out the sympathetic nervous system, reducing sympathetic tone. So please do not confuse central alpha agonists, which work on the brain, with peripheral acting alpha blockers that we talked about in high blood pressure as well. So clonidine, catapress, is our typical central acting alpha agonist. So clonidine has some other interesting uses as well. Remember, we use central alpha agonists. We'll use central alpha agonists in glaucoma as well. And so clonidine, catapress is one of our centrally acting alpha agonists. I think you have a list on your clinical discussion. All right, hydrochlorothiazide is a diuretic. We'll talk about diuretics. We'll talk about diuretics next time. Hydrochlorothiazide, abbreviated HCTZ. Here we have 25 milligram tablets. You'll notice in your list of drugs in your clinical discussion guide that we can add hydrochlorothiazide to just about, we add hydrochlorothiazide to any of the other classes of antihypertensive, and we'll get a little bit better effect. And you'll notice some of the combinations don't have 25 milligrams. Maybe they just have 12.5 milligrams or even less than that in combination with the other antihypertensives. And again, when you have one name that has two medications, then that is two different drugs. And so sometimes we'll mix them together to improve patient compliance. They'll be like, well, I'm not taking two drugs, I'm only going to take one. And we're like, okay, well, we'll just take two drugs and put it in one pill. And then you think that you're taking one medication. That's not the case at all. When you look at the combination drugs, you'll notice that those are two medications in one. And so I want you to see those as two different drugs, and there's two different monographs for each of those different drugs. Many times the combination will be far more expensive if they just took it separately. And so, you know, Uncle Bob, he won't take blood pressure pills because he's not taking two different pills. It's like, okay, we'll just take the one pill. Oh, it's so expensive. I'm like, well, it'd be cheaper if you took the pills separately. And so this is something that we have to go through when we're trying to teach our patients to take medication. But the point here is a little bit of hydrochlorothiazide goes a long way in treating high blood pressure. Now, when we talk about diuretics, we're going to talk about hydrochlorothiazide, and we'll talk. You know what? We'll talk about hydrochlorothiazide when we talk about diuretics. All right, angiotensin converting enzyme inhibitors are also used as antihypertensives because, again, renin is released from the kidneys into the body, and that's the kidneys yell for help. It's saying, help me, I'm not getting enough blood supply, and so the body needs to do something about that, and the renin converts angiotensinogen to angiotensin II, and angiotensin II is a vasoconstrictor. So angiotensin converting enzymes prevent the formation of angiotensin II. And so that's how they dilate. So angiotensin converting enzyme inhibitors prevent the formation of this vasoconstrictor. But again, we'll use ACE inhibitors for other things besides just high blood pressure. So be careful about listing ACE inhibitors as antihypertensive. Ooh, this is important right here. Angiotensin converting enzymes can cause this short, dry, barking cough, and so you'll have somebody and you put them on ACE inhibitors. Now there's a little cough, and angiotensin-converting enzymes can cause cough. The mechanism for that is long and complicated, not as simple as beta blockers, but beta blockers cause cough. Angiotensin-converting enzymes can cause cough as well, and so this will be something we want to be careful of in our asthmatic patients, our chronic obstructive pulmonary disease patients. And just be careful. You'll give this to somebody, and out of the blue, they'll start coughing, and they'll think it's due to something that they ate from farmer's market or something like that. So you need to be able to make this connection. Please don't forget this. If this slide wasn't there, I think I would have forgotten to tell you. Capitan captopril is our typical ACE inhibitor. There's a huge list of ACE inhibitors, and despite what the drug reps will tell you, all the ACE inhibitors are going to read exactly like this ACE inhibitor here. So get the package insert out for captopril. Find that on Daily Med. Again, those instructions are in your syllabus. And know how to look at the package label of one drug like this and realize that that package label is going to read the same as the other drugs in its class. And again, it's the similarities that I want you to know, not the differences. I don't need you to know the names of all the different ACE inhibitors. I want you to know as much as possible about one of them. And then you can translate that into the other ACE inhibitors. And again, I don't want you to memorize any of this stuff. I want you to look it up over and over and over again until maybe you can recite it off the top of your head in front of a camera with a little bit of memory aid. And then you can teach this class. That's what 14-hour days is doing. Angiotensin receptor blockers, well, instead of interfering with the formation of angiotensin II, we can just block the receptor. All right, so angiotensin II, again, is the vasoconstrictor from renin converting angiotensinogen to angiotensin 1 going to angiotensin 2, and angiotensin 2 is the vasoconstrictor, but maybe we can just block the receptor, and so that's why they call them ARBs, angiotensin receptor blockers. Right? And keep in mind the ARBs end in the word sartan. So the generic term is the word sartan. So losartan is COSAR. It's an angiotensin II receptor blocker. And there's all sorts of sartans out there that are the angiotensin II receptor blockers. Right? Calcium channel blockers are interesting because they interfere with calcium channels. They can relax the smooth muscle, the muscles not only in the heart, but arterioles, blood vessels as well. Okay, so that's why that little icon's on there. We're going to divide the calcium channel blockers into 3 classes: dihydropyridine, generic terms, and then dipine the majority of the time, and then verapamil and diltiazem. I want you to know that they're 2 drugs in a class by themselves, whether they're phenylalkylamines or benzothiazepines. I don't use that word much. I know that verapamil and diltiazem are in a class by themselves. They have uses that the dihydropyridines don't have. And so what I want you to know is there's lots and lots and lots and lots and lots and lots of dihydropyridines out there. The list in my clinical discussion is short. You can go to drugs.com/professional and enter dihydropyridines, and they'll give you this long list of calcium channel blockers. And when you read the package insert for dihydropyridines, they're pretty much all the same. There are a few dihydropyridines that are going to work better in some ethnicities than others. That's something I want you guys to look up in your clinical discussion section. Those of you who like to look things up and email me when I ask for them. What are the ethnic differences in the treatment of high blood pressure? And I know I have a great write-up somewhere. Maybe I'll put that in your resources section. Norvasc is one of the medications that's going to be indicated in certain ethnicities, and other people aren't going to respond to it as well. So amlodipine Norvasc is a dihydropyridine calcium channel blocker. It does have some uses that are different than the other dihydropyridines. Nifedipine, Procardia Adalat, it's a dihydropyridine, pretty much like all the other ones. Verapamil is a calcium channel blocker. We're going to use it when we talk about cardiac rhythm. We can use it as an antihypertensive, but it has some rhythm things that we're going to talk about. Same thing with diltiazem. All right, so there are calcium channel blockers in a class by themselves. All right, well, something that's interesting is nimodipine, Nimitop. is a calcium channel blocker, a dihydropyridine. Here's a dihydropyridine that's completely different than the other ones. It can cross the blood-brain barrier. And so not only will nimotopine will be used as an antihypertensive, but because it gets into the brain, we're going to use it in neurosurgical or neurological ICU to treat cerebral vasospasm. And so somebody has some kind of head injury, where especially if they have some kind of bleeding injury in their arachnoid space, that blood is very irritating to the blood vessels. The blood vessels will vasospasm in the brain in response to not only trauma but blood, and we can give them calcium channel blockers to maintain open blood vessels. And so you'll see some people take Nimotop as an antihypertensive because it's a dihydropyridine, but maybe you'll be in a neurosurgical ICU where we're using a nimotopine as to prevent cerebral vasospasm. So start out by taking a step back and just being able to memorize this with your eyes closed. Beta blockers, alpha blockers, central alpha agonists, hydrochlorothiazide, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers are the main categories of antihypertensives. Of course, there's a few others, and I think I cover those as well in your clinical discussion pages, which will have another name someday. But until then, I've already talked about glaucoma. So this is where I get to stop. The glaucoma lecture is on the end of the 2.2 autonomic pharmacology lecture, for those of you ever watching reruns. So we'll end that right here, and when I come back, we're going to talk about diuretics and antilipidemic agents, and that'll be 2.4. Until then, aloha.